Hello students, so now let's discuss all the formulas you have to remember in PK, that is pharmacokinetics. So beta, we discussed pharmacokinetic is ADME study, that is absorption, distribution, metabolism and excretion, which is also together known as elimination. So in absorption, we calculated a formula for BA. Symbol was F. So BA was bioavailability of a drug. And its formula was area under curve of concentration time graph. Let's say you have given a drug orally and divided by area under curve when you have given a drug IV. That means when a drug enters into the blood, the area in oral will always be less, and in IV, the area under the curve will always be high because IV routes, they have 100% bioavailability. So can we say in oral route, we have to give a little bit higher dose of a drug to maintain that same area? So it is also known as dose given IV upon dose of a drug given orally, because the oral dose will always be higher. So this is the formula of bioavailability, and the symbol of bioavailability is F. F means fraction. Now in distribution, we discussed about a formula known as volume of distribution. So it is dose given IV upon plasma concentration measured. Fine. So can we make this formula as for oral dose as VD is equal to dose given orally multiplied by F. F is bioavailability divided by plasma concentration. Because I have, instead of IV, I have used this formula. And lastly, in elimination, we discussed the formula for elimination. Elimination is equal to clearance into concentration of a drug. And this is the formula of first order kinetics. So we only discuss elimination in first order kinetic. Zero order kinetic has a very complex formula which we don't have to discuss. So overall, if you see, this was the first formula, second formula and third formula. These three formulas we have to discuss. We have to learn. Now, we will derive three more formulas. 1, 2, 3. From this dose, which we have written IV dose, we will derive a formula. This dose is known as loading dose. So let's write it as loading dose IV. This loading dose is equal to volume of distribution into plasma concentration, which you want to achieve in the blood. So loading dose formula comes from volume of distribution, fourth formula. And from elimination, we will derive another formula of maintenance dose. And I will be telling you that maintenance dose is nothing. It is equal and opposite to elimination rate. So elimination and maintenance dose, they have same formula. So maintenance dose is clearance into plasma concentration which you want to achieve, which is the fifth formula. So can we say loading dose depends upon volume of distribution into plasma concentration? Maintenance dose depends upon clearance capacity into plasma concentration. Now from these two formula, we determine the sixth formula, that is formula of half-life of a drug, T half, which is 0.693 Vd upon Cl, volume of distribution upon clearance capacity. So these are the formulas we have to remember in pharmacokinetics. Okay? Now, we have not discussed till now three things. First is half-life. We are going to discuss in detail. What is this loading dose? What is this maintenance dose in greater detail? So let's start first with half-life of a drug. That is T half. Okay? And we are discussing half-life in context of first order kinetics. So half-life means time required to reduce plasma concentration of a drug by 50%. That if a drug is present in plasma, in how much time it will become half. In plasma, this is half-life. But there is a point out here. If you remember the formula of half-life, it is 0.693 Vd upon Cl. From this formula, can you tell me half-life of a drug does not depend upon? Half-life of a drug does not depend upon. Options are absorption, distribution, metabolism, and excretion. Can you think about the reason? Remember, in distribution, we discussed about volume of distribution. In metabolism and excretion, we discussed about clearance capacity. So, half-life of a drug does not depend upon absorption. And now, let's complete the definition of half-life. Half-life is the time required to reduce plasma concentration of a drug by 50% after the drug has been completely absorbed. After the drug has been completely reabsorbed is half-life of a drug. So when the drug finally enters into the plasma or blood, then we start calculating the half-life of a drug. So half-life of a drug does not depend upon absorption, and this question can be asked in a twisted way. Twisted way means, in absorption beta, we discussed about route of a drug administration. We are giving a drug oral, IV, and by many routes. Remember, half-life of a drug does not depend upon route of administration also. The reason is, if you give a drug by any route, we don't care. We start calculating half-life after the drug gets completely reabsorbed. Completely absorbed, okay? Now let's talk about, again, this formula of half-life. So half-life formula, we have written as 0.693 Vd upon Cl. Now let me explain you this point of half-life. Suppose, sir, you have given a drug and now the drug has been completely absorbed into plasma. Now drug is present into the plasma. Now where this drug can go? First point, this drug can enter into the organs. Agreed? And the drug which is entering into the organ, we call it as Vd. Vd is volume of distribution. So when we give a drug, the drug suddenly enters into the organ. So let's make a graph. So I have given a drug which is present in plasma concentration and time. The drug suddenly reduces in plasma. Why the drug suddenly reduces into the plasma? Because the drug is entering into the organs. VD. Fine. Now, this first phase of reduction in plasma concentration is because of distribution of the drug. Now what happens? This drug gets slowly exchanged, and now this drug slowly and slowly again comes back into the plasma, because the drugs, most of the drugs are reversibly attached to organs. Now this drug slowly enters back into the plasma. Now the drug which is slowly entering into the plasma will now slowly and slowly excreted out into the urine. Now the drug will get slowly excreted out into the urine, and the power of an organ to eliminate a drug is known as CL. Now power of a drug to eliminate a drug is known as clearance capacity. Now what will happen? Now this drug, again, slowly and slowly this drug gets reduced in the plasma. Why? Because the drug is coming from the organs into the plasma, and this drug is getting removed into the urine by clearance capacity of an organ. Agreed? Now, a very important concept which you students don't understand. Beta, we start calculating half-life from this area. This is the area from where we start calculating half-life. So after the drug gets distributed into the organ, now it is again coming back into the blood. We start calculating half-life from here. Because now the drug is only getting eliminated into the urine, and the drug is coming into the blood from organs. So this phase we calculate half-life. This initial phase we don't calculate half-life. So see the formula again. Can we say if a drug has high volume of distribution, more drug will come into the plasma, and more drug will remain in the plasma for longer duration of time? Hence, the drug will take more time to become half. That is why half-life of a drug is directly proportional to VD. If a drug is more distributed, it will be coming into the plasma, and the plasma concentration will not fall. And if the clearance capacity of an organ is very good, the drug will be removed out of the body very fast. That is why half-life is inversely proportional to clearance capacity. Half-life of a drug is inversely proportional to clearance capacity. So let me write this formula again for you. So half-life of a drug is directly proportional to volume of distribution divided by clearance capacity. So now, from where this 0.693 has come, 693 is a value of log 2. And we discussed in first order kinetic how the plasma concentration of a drug falls. In first half-life, the drug becomes 50. In second half-life, the drug becomes 25. Then 12.5, third half-life. So this pattern of decrease in plasma concentration is known as exponential decrease in plasma concentration. That is 100, 50, 25. And when anything falls exponentially, we apply log. So that is why 0.693 is the value of log. So this formula is a formula which you remember by heart. Now beta, we know how to calculate VD. We also know how to calculate clearance capacity. From this formula, we made another formula. That is half-life is equal to 0.693 upon K. 0.693 upon K. Now, can you think what K stands for? K stands for clearance upon VD. If you see this formula, we have applied K in denominator, hence K is CL upon VD, and this K is also known as elimination rate constant. What is K known as? Elimination rate constant. So half-life is 0.693 upon elimination rate constant. So let's talk about half-life in more detail and in more simpler terms. So let's say half-life, let's make a diagram. Half-life, plasma concentration of a drug, and how much drug gets eliminated finally. Let's say, beta, you have just given a drug to your patient. At this moment, let's say the drug is not eliminated in 0 time. Can we say in plasma the drug is 100% and it is 0% eliminated? So beta, what happens in first half-life? In first half-life, the drug becomes 50. After first half-life, plasma concentration becomes 50%. And how much drug gets removed out of the body? 50%. Similarly, in second half-life, the drug becomes more half, 25, 75. Sir, in third half-life, 12.5, 87.5. So keep on dividing like them. So keep on dividing them and let's write till fifth half-life. So 6.25, 93.75, 3.125 another half, 96.875. Now sir, why we are writing such a simple maths? Because in exams, you don't get much time. So let's revise it here. And tell me the answer of first question. Can you tell me in how many half-lives 90% of the drug is eliminated? 90% elimination occurs in how many half-lives? I will give you the options. Options are 2.3 half-life, 3.3 half-life, 4.3 half-lives. This question was asked once. Now, if you want to see 90% elimination, it is somewhere 90%. And can we say 90% elimination is occurring between third and fourth half-life? So now, can you guess the correct answer? The correct answer will be 3.3 half-life. Now, in exam, we don't have time. So please learn it or cram it. Now, another question. Let's see which student can answer. 95% elimination can occur in how many half-life? So if you want to see 95%, we have to find between fourth and fifth half-life, 95% elimination. Agreed? So 95% elimination occurs between 4th to 5th half-life. Very commonly asked question. Now, a very complex question. Can you tell me 100% elimination occurs in? 100% elimination occurs in. The answer is infinity. Never. Why? Because everything has a half value. So you cannot calculate 100% elimination. It is not defined. This is infinity. Now, when anything becomes infinite, that means we cannot define. Hence, in pharmacokinetics, we have to make an assumption. Because it is not defined, hence we make an assumption. So that assumption in pharmacokinetic is that if a drug is more than 95% eliminated, if a drug is more than 95% eliminated, we assume complete elimination of a drug. We assume complete elimination of a drug if a drug is more than 95% eliminated. So now can you tell me complete elimination of a drug occurs in how many half-life? Complete elimination of a drug occurs in 4 to 5 half-lives. And if you get both option 4 and 5, you should go by 5 half-life, greater half-life. And in complete elimination, we have seen that if a drug is more than 95% eliminated, its action in the body is over. So if its plasma concentration falls by less than 5%, its action is over. So let's write this point again. So one assumption in pharmacokinetic is that if a drug is more than 95% eliminated, that means its plasma concentration is now less than 5%. We assume complete elimination of a drug from the body. We assume complete elimination of a drug. So tell me, complete elimination of a drug occurs in how many half-lives? 4 to 5 half-lives, and 5 is a better answer. And in complete elimination, the action of a drug is over. So let's see the importance of this point in our patient. If I'll give you an example, there is a drug known as lithium. And if I say the half-life of lithium is 1 day, and patient is taking lithium from many months, and today patient has stopped taking lithium. So today patient has stopped taking lithium. Can you tell me the action of lithium will get over after how many days of stopping? So lithium concentration, complete elimination will occur in 4 to 5 days. So today if you will stop lithium, its action will get over after another 4 to 5 days. So action of lithium will get over around 5 days after stopping lithium. Okay, so this is the importance. So if we stop a drug, after 5 half-lives, the action of drug gets over. But because this is an assumption will have drawbacks. So exception to this rule is a class of drug known as hit and run drugs. Hit and run drugs, they don't follow this assumption. So let's write, what do you mean by hit and run drugs? And the definition of hit and run drug becomes very easy now. Hit and run drugs, they continue to produce action in our body even after complete elimination from blood. Complete elimination from blood or plasma. So even if their concentration falls by more than 95%, they continue to produce effect. Let's see the reason why it happens. So beta, I have told you when we were discussing half-life, a drug goes to the organ, and most of the drugs, they are reversibly attached to organ. That means they again come back into the blood. For a moment, assume this drug is not coming back into the blood. That means this drug has been attached to the organ irreversibly. Now, if this drug is attached to the organ irreversibly, don't you think the action on the organ will continue to come? And these drugs are not present in plasma. So these drugs you will not found in plasma. Their concentration will be very less. and you assume the drug is eliminated because the concentration falls. But the action on the organ will continue to come. So this is hit and run drug, because hit and run drug, they bind to their target organ. In which fashion? They bind to their target organ by irreversibly. They bind to their target organ irreversibly. Beta, irreversibly means which bond? Covalent bonds. There is another bond known as ionic bond. Ionic bonds that are reversible bond. Covalent bonds are permanent bond. Now hit and run drugs, hence they are also known as suicide inhibitors. Because let's say if they are binding to some enzyme or receptors inside the organ, can we say that enzyme or receptor will now never work? It is permanently dead. So hit and run drugs, they are also known as suicide inhibitors. So first let's write the examples of hit and run drugs. The mnemonic is MUGRA. M for MAO inhibitors like tranylcypromine. So if you cannot remember tranylcypromine, fine. Then omeprazole. Heard about omeprazole? Which class of drug? Proton pump inhibitor. So all PPI, that is proton pump inhibitor, all types, omeprazole, pantoprazole, rabeprazole, they are irreversible inhibitor of one transporter in stomach, that is hydrogen potassium ATPase. H plus K plus ATPase. H plus in chemistry is also known as proton, and they inhibit this transporter irreversibly and they reduce acid production. Then organophosphate. Okay. Guanethidine, reserpine, and a very important drug, aspirin. Aspirin inhibit one enzyme known as COX enzyme, cyclooxygenase, short form COX, 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 irreversibly. It's an example of hit and run drug or suicide inhibitor. Now, what is the importance of this point? Let me explain you. If I say that half-life of aspirin is just 2 hours, so can you tell me in how much time will it be completely eliminated? Half-life in plasma is 2 hours. Multiplied by 5, 10 hours. That is 10 half-life. So, 5 half-lives. So, can we say after 5 half-life, that is 10 hours, aspirin will be eliminated from plasma. But the effect of aspirin, let's say on platelets or any other organ, continues to come for 7 to 10 days. That means aspirin continues to produce effect even after complete elimination. The reason is very simple. Aspirin is an antiplatelet drug. And aspirin binds to platelets, and in platelets it inhibits COX enzyme irreversibly. Fine. Now this platelets cannot work. The life of the platelet is 7 to 10 days. So the effect of aspirin as an antiplatelet drug, it comes for 7 to 10 days. So I'll write 7 days because it is binding to platelet irreversibly and you will not find aspirin in the blood. So can you tell me, antiplatelet drugs, they can cause bleeding. And we don't want bleeding during surgery. So antiplatelet drug like aspirin should be stopped how many days before surgery? So aspirin should be stopped 7 days before any major surgery. before any major surgery, because its action on platelets continue to come. Okay? So this is the importance of hit and run. Now let's talk about what do you mean by that loading dose, maintenance dose, which we have written. To understand loading dose and maintenance dose, first we must understand a principle known as plateau principle. Plateau principle, it is also known as steady state concentration principle. So, plateau principles tells us about steady state. Now, what do you mean by steady? Steady means anything becomes steady. It is not fluctuating anymore. Plateau also means anything which is not fluctuating becoming flat. This is plateau principle. Now, in simple words, what is plateau principle? Let me get back again to you. So, this was plasma concentration and this is time in half-life. Can you recall and tell me after how many half-lives the drug gets reduced in plasma by 95%? 95% concentration falls in how many half-life? 95% concentration of a drug falls in plasma in 4 to 5 half-lives, which we just discussed. Now let's make it opposite. Now what I have done, I am continuously giving a drug to your patient, to a patient. If I am continuously giving a drug to a patient by a constant rate, its 95% concentration in plasma will get achieved in how many half-life? Again, 4 to 5 half-lives. And now you can see the concentration is becoming steady. Or it is achieving a plateau. So if you give a drug continuously, it will increase, and after 4 to 5 half-life, the concentration in plasma becomes steady. Agreed? This is plateau principle or steady state principle. So let's write this thing in word format. So what plateau principle says? Plateau principle says that if a drug is given by constant rate, we are not changing the dose of a drug, we are every time giving same dose, its 95% concentration in plasma achieves in 4 to 5 half-lives. This is a question. And this concentration, we call it as steady state concentration. Now, beyond this, if we keep on giving the drug, beyond this, there is no significant increase in plasma concentration. If we keep on giving the drug further, there will be no more increase in plasma concentration. It becomes steady because at this steady state concentration, the rate of infusion, the rate by which we are giving the drug, becomes equal to rate of elimination. So rate of infusion matches to rate of elimination. That is why the concentration becomes steady. That is why the concentration becomes steady. So this is plateau principle. Let's make it simple and make a diagram of it. So plasma concentration, time in half-life. So just make a graph like this. So this is steady state concentration. And this steady state concentration of a drug is achieved in how many half-life? You will write 4 to 5 half-life. And at this steady state concentration, the rate of infusion of a drug becomes equal and opposite to rate of elimination of a drug. That is why the concentration does not increase or fall any further. Now beta, every drug has their steady state concentration. This happens to all of the drugs. And in every patient, we want to achieve this steady state concentration because the drug is not fluctuating. So we want to achieve this steady state concentration in our patient. Sometimes we call this steady state concentration which we want to achieve in our patient as target concentration. We call it as target concentration also, which we want to achieve in our patient. Now let's see how we can achieve this steady state concentration. So let me make this diagram for you. Very easy. So we want to achieve this steady state concentration. Let's write the symbol of steady state concentration as CSS. Why CSS? C means concentration. SS means steady state. It is also known as target concentration. Now, and it is getting achieved in 4 to 5 half-life. Okay. Fine. Now beta, just imagine there is a drug lithium and lithium has a half-life of 1 day. So just think, I have started lithium today and I am continuously giving every time same dose of lithium by constant rate 100 milligram I am giving every day. So if I say the half-life of lithium is 1 day, you start lithium today, its steady state concentration will come after how many days? Yes, that is 4 to 5 days. So if you will start lithium today, its steady state concentration will come after 4 to 5 days. And then the effect of lithium will start coming. So it will take 4 to 5 days. Now my question is, sir, there is some emergency. Can you wait for 4 to 5 days? The answer is no. We cannot wait for 4 to 5 days. So sometimes in initial 4 to 5 days, I will give a little bit higher dose of lithium. So if I will give a little bit higher dose of lithium to achieve this steady state concentration rapidly, this initial higher dose of lithium or any other drug is known as loading dose, also known as initial dose. So sometimes we give a little bit higher dose of drug to achieve this concentration rapidly, that is loading dose. So loading dose is given to achieve steady state concentration or target concentration rapidly. Because we don't have time, 4 to 5 days, there is an emergency. Okay. Now next point. Now you have achieved this steady state concentration by giving a little bit higher dose. Now at steady state concentration beta, we know the rate of infusion becomes equal to the rate of elimination. Now we want to maintain this steady state for long term. Don't you think whatever the drug is getting eliminated, if we give this drug from outside, the concentration will remain steady? So that second dose after you have achieved steady state is known as maintenance dose. So maintenance dose is given after you have achieved steady state concentration and it is given to maintain steady state concentration. Now, a very important point, can we say maintenance dose and elimination rate, they both are equal and opposite? So whatever the drug is getting eliminated, just give this drug from outside, concentration will fall. Maintenance dose and elimination are equal and opposite. So we give two types of doses in our patient. The first is loading dose and second is maintenance dose to achieve our target concentration or steady state concentration. So that target concentration we can achieve by a strategy. First give loading dose and then give maintenance dose. So loading dose is also known as initial dose. Maintenance dose is also known as dosing rate because you are repeating the dose with the time, dosing rate. Now, loading dose is given, it is the higher dose to achieve steady state or target concentration rapidly. Okay. Maintenance dose, it is given after steady state is achieved. Now, how do we calculate loading dose? IV. Loading dose is equal to volume of distribution into target concentration which you want to achieve. While maintenance dose, it is equal to clearance capacity into target concentration which you want to achieve. Can we say the formula of maintenance dose and elimination rate is same? Elimination is also clearance into target concentration. Okay. So beta, can you tell me the units of loading dose? Yes, we can calculate. Volume of distribution was liters or ml. Concentration is milligram per ml. So ml and ml will cut down. So the units of loading dose is only and only milligram. And beta, what was the units of elimination? Elimination was milligram per minute. So that is why the units of maintenance dose will also be milligram per minute. In simple words, we can remember like this. Loading dose is the first dose we just give. And maintenance dose is the dosing rate. Dosing rate means this much amount of drug I will repeat in this much amount of time to maintain steady state concentration. So tell me which dose depends upon time. It is loading dose or maintenance dose? Yes, it is maintenance dose. So let's write few other points of difference between loading dose and maintenance dose. So loading dose does not depend upon time. And we can write it does not depend upon the half-life of a drug. While maintenance dose depends upon time. And maintenance dose depends upon the half-life of a drug. If a drug has a very long half-life, we have to repeat the drug after a very long duration of time. If a drug has a very short half-life, it falls very rapidly in blood, we have to repeat the dose very fast. Agreed? Now, loading dose, it is given for high VD drugs because volume of distribution determines loading dose. So, it is given for high VD drugs maintenance dose is given for high clearance drugs. So if a drug is getting repeated very fast, we have to give higher amount of maintenance dose. So loading dose depends upon volume of distribution. Maintenance dose depends upon clearance capacity of a drug. So this is very important. Now beta, let's make this thing a little bit more applicable to our patient. Let's say there is a patient who is having renal disease. Can we say that in renal failure, kidney is mainly responsible for elimination of a drug, and kidney has some clearance capacity to eliminate a drug? In renal failure, what happens? Because the kidney is damaged, the clearance capacity of a drug reduces. So clearance capacity of the body gets reduced. So can you tell me, in case of renal failure, which dose must be reduced? Is it the loading dose or maintenance dose? Yes. In renal failure, reduce the maintenance dose of a drug. So we have to give lesser dose as a maintenance dose because maintenance dose was depending upon clearance capacity into target concentration. So if clearance capacity gets reduced, you have to give lesser dose to maintain to achieve that target concentration. So we reduce maintenance dose of a drug in renal failure. There is no need of modification of loading dose. No modification of loading dose is required. So in renal failure, we reduce maintenance dose of a drug. Now let's talk about dosing in old age patient, that is geriatrics patient. So beta, what happens in old age? In old age, with the time, there is reduced clearance capacity of kidney. How the clearance capacity gets reduced? You know that drug is eliminated into the urine by glomerular filtration, active tubular secretion. So there is decrease in GFR with age. So can you tell me which dose must be reduced? So you will write, we reduce maintenance dose in old age. And there is a class of a drug known as antibiotics like aminoglycoside. Aminoglycosides are the antibiotics like gentamicin, you must have heard, streptomycin. These antibiotics, they are excreted into the urine by glomerular filtration. That is why this MCQ comes, aminoglycosides require dose reduction in old age patients. But which dose I am talking about? Is it loading dose or maintenance dose? Yes, it is always and always maintenance dose. Okay. Now, last point is dosing in children. Now remember, children are not young adults. They are not smaller adults. Children, they have different physiology, different metabolism. Everything is different in children. So how we calculate dose in children? The best method of calculating dose in children, calculating dosing in children is calculate the body surface area of a child and give the dose of a drug according to body surface area. There are various methods of calculating body surface area. Just remember one method or formula to calculate body surface area, Du Bois formula. Just remember the name. We don't have to remember the formula. It is now readily available in calculators. We can do that. But most of the time, we don't calculate body surface area. It is difficult and tiring process. So the most common method of calculating the dose in a children, we calculate child dose from adult dose. So whatever the dose we give in adult people, from there we calculate child dose. Although it is not the best method. And there are certain formulas to calculate child dose from adult dose. First is Young's formula. And this Young's formula is asked. So you know children are young people. So Young formula. Other formulas are Clark's formula and Dilling's formula. Now, you just have to remember the name, and only one formula you have to remember. That is this Young's formula. So, how do we calculate child dose from adult dose in Young's formula? So, child dose is equal to adult dose multiplied by age of the child divided by age plus 12 divided by age plus 12. So adult dose, age into the child upon age plus 12. This is Young's formula. This is how we calculate the dose in a child by Young's formula. But best method is body surface area. And this finishes our loading dose, maintenance dose, and dosing in renal failure and special age group. Best wishes. Thank you very much.